to start the program now. Everybody have a seat, please. Waiting for service here. Good morning. Thank you so much for coming to our league meeting. It's going to be a very popular one, as you can tell. I'm Joanne Marie, president of this league, and I'm so happy to welcome you all on behalf of our league. We have a lot of things to go over with today, so I want to read off my script if you don't mind. A little bit about us. The league is a grassroots, nonpartisan political organization dedicated to encouraging citizens' active and informed participation in government. Since we were founded in 1920, the League seeks to influence public policy through education and advocacy. Some of the issues we are concerned about are educating and engaging voters, protecting voting rights, reforming money in politics, defending the environment, advancing health care, reforming immigration, and fixing fiscal policy, as well as reducing gun violence. So we have a very emphatic agenda. League members are informed about issues because they study the issues before taking a position on them. I invite and encourage you to join our local league. Dues are $60 per year and include membership in the National and State League. Members may be as active or inactive as they choose. I didn't write these words because I don't want you to be inactive. We currently have committee and volunteer opportunities that include Observer Corps, where one attends local government meetings on behalf of the League, clerical and office work that includes Excel and database programs, and organizing event planning opportunities. If you have a minute to join, and we would really appreciate that, Joey Jordan is out front with the membership table, and she'd be happy to sign you up. We also have a needs list, and right now that would be volunteers to assist with upcoming forums. If you haven't participated in the forums in the past, it's a great opportunity to hear candidates and assist the moderators. For more information and to sign up, see Ann or Helen. Ann or Helen. Another announcement, League of Women Voters is very proud to announce we're now supporting California YMCA Youth in Government. See the information table out there about all that. A major function of the League is education and providing information on the election process, and to that extent, in addition to our regular forums, we have a committee hard at work to get out the vote. One of the ambitious goals of that committee, with the support of the board, is to be the county with the largest % of voter turnout in the state. Each election year is an opportunity for change, and this year is certainly no exception. Getting unregistered voters to register and vote provides them the opportunity to be heard. If you have not participated in this process, I recommend you do so. The satisfaction that comes from registering people to vote is enormous and makes us all better citizens in the long run. Our moderator training will take place March 17th. The tentative time is 6 to 8. Is that right, Ann? 6 to 8?
Moderator training, 6:30.
6:30. But do check the website for updates to that information. This training is invaluable in becoming a good moderator, one who is balanced and neutral while conducting the forum, and hopefully thereafter. Speaking of forums, we have some scheduled, and the first one will be the candidates running for the District 1 supervisor position, Heidi Hall and Dwayne Strouser. Why don't you stand up, Dwayne, and Heidi, where are you? There you go. That's April 7th at 6:30 to 9. The other forum dates, and I guess we'll have one after today's news, April 14th, 18th, 28th, and May 5th. Put those dates on your calendar now. More information will be available soon. Kim from, I'm sorry, I forgot the last name.
Kim
Grubbs, thank you. It's going to, for the last 5 minutes of the program, thank you. She's with California Care, and that was the program that helped with community health, and she'd like to just give a... Sorry? Okay. Anyway, she has some information on that. Just the last 5 minutes, if you bear with us. Thank you. And now, may I introduce our co-chair of programming, Karen Schwartz, who will present this excellent panel. Thank you.
So welcome to everyone. We're so happy you could join us today. What you'll be hearing today and seeing is the second in a series of programs that the League has put together to address homeless issues, the issues that homeless people face in Nevada County and beyond. The first program last month dealt with housing issues and how limited the housing options in our area, in our region, and even in the nation are, especially for the homeless population. Today we're going to be addressing other issues that impact the homeless population, and we're very happy to have with us a great panel of speakers. But before I introduce them, I want to describe our format for this day's program to you briefly. The first hour or so will be brief presentations by each of our panelists, so you can learn a little bit about their background, because we seek high and low to find the best informed, most knowledgeable people who have the most experience and background for our panels. So you're very lucky. We're all very fortunate to have these people with us today. After the first hour or so, then you will be able to submit questions, written questions. And who do we have who's handing out? Good. We have cards that we'll be handing out. If you want to ask a written question, raise your hand at any time during the first hour or so, and we will bring a card to you. You can fill out your question, raise your hand when you want it collected, and then those questions will be presented to our panel of speakers. They will not take direct verbal questions from the floor. This is our typical format, no departure here. So the second part of our program today will be your opportunity to hear the answers to your questions from this outstanding panel. Please turn off any phones, beepers, other electronic devices that would distract our speakers and our audience. I'm pleased to have with us today Tom Anderson, Judge of Nevada County Superior Court, who will be introducing the program today and will also be involved in answering questions. And he'll be dealing more with the legal issues. Rebecca Slade, Director, Nevada County Behavioral Health, will be discussing the issues of mental illness and other issues that impact the homeless population. And you all should have a handout that Rebecca has brought. If you don't, there'll be some on the piano that you can collect on your way out. Also presenting today will be Dr. Brian Evans, Vice President and Chief Medical Officer for our hospital administration for Sierra Nevada Memorial Hospital, and Stephanie Kreiter, Community Benefits Specialist, also from the hospital, and Katie Bell, Substance Use Disorder Specialist from Chappaday Indian Health. And she is an expert in the area of addiction and substance abuse issues. So without further ado, we'll begin with Tom, and then Becky has a slide presentation that she'll present to you. Are there any questions? Then we'll begin now.
Thanks. Do you guys want to sit down now or stay away from the light? Stay away from the light? Cowards. Okay.
Maybe we'll sit after this.
Okay. Well, good morning and thanks for being here. And thanks to the League for hosting this topic, and thanks to all of you for showing up. The issues surrounding homelessness, mental health, addiction is obviously more than just criminal justice issues, yet the criminal justice system incorporates many of the important aspects of this issue affecting our community. So we need to look at a broad range of topics, and it's hard to avoid going off on tangents to talk specifically about any one aspect. So most of this is going to be rather broad, and hopefully when we get to questions, we can get to specifics depending on your questions. One thing you will note is the overlap in what each of us talk about, each of the panel members, the terms used, the means available to us, and the obstacles and limitations that we confront. And that's a crucial note, because there is no one way or one agency that can solve this problem. All of these issues overlap, both in concept and in practice. There's no permanent solution to any of these problems. Homelessness, mental illness, addiction, like cancer, diabetes, the common cold, are not likely to disappear anytime soon. They're not going to be eliminated, but we can manage them better than we do. So the real bottom line of this is it takes the village to confront this problem, and we all need to be motivated. So this morning we'll discuss many of the services available, the programs that are ongoing, some of the processes, and some of the problems. We'll not spend a lot of time contemplating specific solutions. That's a much longer marathon program to discuss possible solutions and actions. But we can point and will point to some solutions and approaches, because facilitating these solutions is often the main problem that we have. So obvious and proven solutions do exist to a lot of the issues that face us, but implementing them is the problem, and it's a political problem. So with a better understanding of the issues, hopefully we'll be able to confront them better and have a simultaneously more involved individual and community-based focus. So after that introduction, which was too long already, let me get to the point, and I'll begin with my closing remarks. We have a wonderful community here. We have wonderful community leaders that are really taking upon themselves to try and make our community better. I mean, the members of this panel, for starters, the folks at Hospitality House, Sierra Roots, Divine Spark, Turning Point, CORE, Common Goals, Salvation Army, DVSAC, Food Bank, Interfaith Food Ministry, NAMI, and individuals within various other county departments and nonprofit organizations. These are dedicated folks, and having this many nonprofits and motivated people is kind of what makes our community a special place to live. However, what stirs the pot and what provides care and problem solving and long-lasting impact is leadership. You can feed someone today, you can house them tonight, but solutions have to be ongoing. Homelessness, mental illness, addiction won't disappear, but we can manage them better. But it takes consistent and reliable funding. It takes money from government. It takes our elected and non-elected local leaders to be on the same page to people who know how to deal with these issues and being willing to implement them. That's why, and that's where you all come in, the voters, because it is ultimately a political issue, and we need elected leaders and non-elected leaders who know what they're talking about when they talk, who are willing to be educated, and are willing to be responsive to the greater needs of the community. So, back to the beginning. Last November, the Forensic Task Force on Mental Illness in the Courts, which is a county committee, started back in 1999, thank you, Lael, and has been ongoing in trying to motivate collaboration, cooperation, communication. Put on a symposium on mental health and addiction designed for frontline workers in the criminal justice system. It focused on mental illness education to provide a unified baseline understanding of what it means to be mentally ill and how to interact with that. But much still needs to be done to expand that baseline understanding and acceptance. Some of the programs that exist for this group of people, and I'm trying to use group of people rather than focused population, because we're focused on dealing with individuals and real human beings. So, in the Nevada County court system, we have several programs that deal with this broader issue of addiction and homelessness. And we have drug courts, mental health court, we have Laura's Law, or assisted outpatient treatment court, we have a community court, and our probation department has incorporated a lot of pro-recovery methods in what they're trying to do and have been innovative. Yes, ma'am. Okay. I hate microphones. Anyway. The program's goal are basically to have the participants engage in recovery services, take their meds, stay clean and sober, and follow directions. How they motivate to do that and the impact of that is a much longer discussion. But all these programs work in collaboration. It's not just the court. The court is sort of the host. It requires the participation of many other collaborative partners, including behavioral health, Common Goals, CORE, Hospitality House, the probation department, and of course the district attorney's office and the public defender's office and private attorneys who are willing to get their clients into these programs. And the goals of trying to promote stability and recovery, have a lot of obstacles. Some of them is just in the process itself. For example, when someone on the street gets arrested, first of all, they're detained. Homeless people, their belongings are usually taken. They're put in jail for sometimes hours, sometimes days, sometimes weeks and months. And it all depends on so many variable factors of how long they sit there. And then they come to court, they get an attorney, they're being told a lot of things in a legal language that they don't understand or care about. And then they have to face the entire court process, then sentencing, possibly more jail time, possibly probation terms and conditions that they're expected to follow, and if they don't, they're subject to rearrest, being put back in jail. And so this is a very difficult process, and there's lots of overlapping issues around all of those, as you can imagine. And some of the agencies have noted specific obstacles to what they do, and a lot of it is numbers and money. For example, the Public Defender's Office, which is grossly understaffed, reports 70 to 80% of their clients, 70 to 80% of the clients, and they have thousands of clients a year, have either substance abuse issues, mental illness, or co-occurring disorders. Co-occurring disorders.
Which means
They have both. Substance abuse of some type or another and a mental illness of some sort. 70 to 90% of their clients are effectively homeless. Huge number. And that, when I say effectively homeless, I'm including not just the people that are staying in shelters or camping, but people who are getting by couch surfing, staying in somebody's basement, living in a broken down trailer. They don't have secure, permanent housing. The public defender also has reported a huge increase in the findings of people who are incompetent to stand trial, meaning they're arrested and they're in a mental state where they really can't participate in the process in any knowing, realistic manner. It's a huge increase across the state. There was a recent article a couple weeks ago in the LA Times, a study in LA, and it's come to the point of a crisis in the metropolitan areas, and it's actually a crisis here. The numbers have increased tenfold in the last 2 years. It used to be you would get somebody in a minor case or even a felony case that you thought was incompetent maybe a couple times a year. Now it's monthly. These cases come into court. And there's no treatment, and getting treatment is very slow. The state hospitals, of course, which were closed way back when, haven't reopened and haven't been replaced. And so the wait list for somebody sitting in county jail to get treatment, which they're entitled to by law, turns into months and months and months. And then the treatment, well, that's another discussion. And as an example, going back to cures, obviously one of the solutions is to reopen state mental hospitals for the purpose of diagnostic and treatment of folks. because there's such a huge lack of that. The state's known that for decades, but there's no effort to really deal with it still. Another partner in all these proceedings, the DVSAC, a large number of their victims, most of them need housing, which isn't available. Their larger shelter that they have in town, in the last 8 months, just since last July, has provided over 2,800 bed nights for 57 different individuals. In the last 8 months, they've had 343 new non-duplicated victims come into their walk-in center. For our small community, huge numbers. Probation department, of course, which is trying to incorporate a lot of pro-recovery measures amongst their groups. They're trying to start a job training program, which is going to have some political obstacles to that. But there's no place for people to go once they get out of rehab, or once they decide to come out of the woods. There's no housing for folks. There's no jobs for them to be able to allow them to maintain a stable lifestyle. And all of these programs that I referenced before in the court aren't cheap. Focusing just on the court process and reflecting on costs. When you think of a cost of a criminal case and it comes into court, it's spread along the community. But you have the cost of the district attorney reviewing cases to decide what to charge. You have and that's after the police agencies have made an arrest, an investigation, responded to an event. And then there's the clerk's time in creating and administering the file, or allowing for the case to process through the system. There's the courtroom time of judges, clerks, reporters, bailiffs, attorneys, caseworkers, and others. And the supervision time and reporting time. Yet the problem-solving courts are a lot cheaper than processing in the traditional criminal prosecutions, and they have better results. This means that we know from following evidence-based practices that efforts to solve a problem are more efficient, cost less, and have better results than traditional criminal prosecution and punishment. There have been many studies around the country that have calculated the cost to the community of a homeless person on the street. The cost to taxpayers is approximately about $40,000 a year per person, right? Or higher. And that's slightly less than the cost to keep someone in prison for a year, which is closer to $50,000 or $1,000 a year or more. And most of these costs are spread across the community, with the top 3 costs being hospital, police, and courts. None of those principal costs, hospital, police, courts, involve anything to do with stabilization, recovery, or rehabilitation. Which brings us back to that phrase, evidence-based practices, and why these issues are important to voters. Evidence-based practice refers to following treatment procedures that have proven to be effective in a positive way. For example, we know that putting an addict who gets convicted of committing a crime into prison creates about a 70% chance that they will fail, that they will reoffend when they get out of prison, compared with putting that person into a rehabilitation program or recovery program when they have a little over 60% chance of not reoffending and being successful. And there's an added bonus, because putting someone in prison is about, like I said, over $50,000 a year. Putting someone in recovery is about $15,000 a year. And yet our primary focus is keeping our prisons full. So focusing back on homeless specifically, the studies have unequivocally shown the savings by providing housing. Simply stated, if it costs over $40,000 to keep somebody on the street, it costs, depending on the town, $10,000 to maybe $17,000 to put them in a house. And Becky will talk more about that specifically. And add to that fact, evidence-based practices, using things that work, show that when a person has a safe place to live, food to eat, they tend to thrive. They can focus on their recovery. They can focus on their medical needs, getting stable. They don't get arrested. They don't go to the ER. They don't get placed in a facility, and they sometimes get jobs, and they become a more positive member of the community, reminding us that they already are a part of the community in the crisis state. And if we can eliminate that crisis state, then we have a positive member of our community. Somebody we're not embarrassed to step over as we walk down the street because they're not laying there. And we are fortunate in our county to have a progressive behavioral health department, which is always trying to find better ways to improve services. We're fortunate to have a place like Hospitality House, which provides a much necessary emergency shelter program for homeless individuals and families. And we have some limited transitional housing programs. But it's permanent housing that's needed, and it's permanent housing that provides the long-lasting impacts and saves even a lot more money. Emergency or sheltered housing is the most expensive service that we provide. Shelters are absolutely necessary, but having temporary shelter is just a Band-Aid, not a cure. So to properly address the issues, communities must look to the real solution, which is housing first. Housing has been identified as the primary need for successful intervention and treatment by the courts, public defenders, probation, DVSAC, Hospitality House, NAMI, name it. Everybody agrees with that fundamental issue as the cure. But getting to that solution is the difficulty and the political issue that we face. As I think Utah Phillips used to adamantly remind us all, a person needs a safe place to live, good food to eat, and a meaningful job. And that applies to everyone, whether you're healthy, ill, addicted, or just plain down on your luck. So, getting on and going into more specifics with all these, I'll turn the mic over to Rebecca Slade from Behavioral Health, but with one quote before I leave you. Even if you don't think society has a moral obligation to care for the least amongst us, the results of all the recent studies underscores that we have a financial obligation to do so.
First of all, the prevalence of homelessness in our community and nationwide in the state of California. I'm going to talk about the cost of homelessness. Okay.
Could you stand in the front?
I'm going to stand over here just so I can keep up with my PowerPoint. How about that? Is this okay? Yeah. Is it on? Oh, okay, sorry. What I'm talking about, and then I'm going to talk about what behavioral health is doing in our community. Homelessness is decreasing nationwide, except for in the state of California. California has the largest chronically homeless population in the nation, and so these are HUD numbers, and what HUD has asked for smaller counties is that we come together. So our Nevada County and Placer County numbers at our last homeless count was 796. So California has almost 115,000 people that are homeless every night. We have 21% of the nation's homeless. 1/3 of them have a chronic, serious mental illness. And here's the Nevada County numbers at our last homeless count. I have the homeless count over here if you want to see that. So what it is showing is that we last, in 2013, we had 314 homeless people, and it's gone down to 279. You know, what we really know about homeless counts is that you usually double that number and sometimes triple that number, especially in rural areas, because in rural areas, it's, people essentially hide. So those are our numbers. And the homeless count is, oops, sorry guys. So the homeless count is done, has been done every other year. We're going to start doing it every year. And it's done by HUD regulations. It's done on January 26th, and the surveying is done for 4 or 5 days afterwards. And you count the number of unsheltered folks, and you count the number of sheltered folks. And I'll show you our numbers in a minute. But, you know, we talk about the cost of homelessness. I'm going to talk about the cost of homelessness to our society, but really, obviously, the cost of homelessness, let's just talk about it, what it does to people. If you have any issue, it's going to be grossly magnified. And here's a list of a few things. Here's another list of more. And what we know about our homeless folks is they're very frequently victims of crime. The list speaks for itself. But the cost of homelessness not only, they also affect us as a society. What we find is radical increase in hospitalization use. So in Hawaii, they found that the homeless population used psych hospitals 100 times more frequently than folks who are not homeless. The New England Journal of Medicine found that the average homeless person spent 4 extra days in a hospital when they were hospitalized. In West Virginia, this was an incredibly big study. They found that homeless patients made emergency room visits 4 times more frequently than the rest of us. And the cost of homelessness for incarceration, where homeless folks get incarcerated often. And in Austin, Texas, they found that they were spending about $14,000 a year on incarcerating the homeless population. And I really looked hard for how many of our law enforcement calls were about folks who were homeless, and couldn't find anything. And I spoke to Joseph Salivar, who is our Nevada County Undersheriff, who said, no one tracks police calls by socioeconomic status, and how much we spend on the homeless, he said, is a lot. And our emergency shelter costs are approximately $8,000 per year for people. Wait a second. Yeah, for $8,000 per year if they have a Section 8 housing. So that's important. You'll see why that's important in a little bit. Okay, so Los Angeles has just recently done this huge study about the homeless in their community, and they're putting a lot of money towards it now, which is exciting. And what they've found is in Los Angeles County, they're spending $1 billion per year managing homeless people and helping them with their health care needs. And here's the breakout of how that money was spent. It was spent on mental health treatment. It was spent on food stamps. It was spent on public social services and medical care, so that it's a little more broken out. So what we found is that if we were to house someone in permanent housing, this is our blue, and it's much cheaper than housing someone in transitional housing, which is our green. And also in terms of recidivism, how many people return to homelessness? What we find is in permanent housing, much lower amount of people return to homelessness versus in transitional housing or no shelter at all. So it's been long-term knowledge that it is much cheaper to offer people permanent housing. And so Sean Donovan, the HUD secretary in 2002 said, before placement, homeless people with severe mental illness used about $40,000 per person. These are the 1999 numbers. And placement was associated with a reduction of services to $16,000 per year. But even before that, in President George W. Bush's time, Philip Mangano, and I think that's how you said his name, said that they did research with 65 different cities. By the way, really hard to find research on rural areas. I really looked hard. Found that the cost of keeping people on the street totals is between $35,000 and $150,000 per year. So, mental illness and the homeless. So a really conservative estimate is that about 25% of the homeless population in the United States suffer from severe mental illness. So what's severe mental illness? Yeah, severe mental illness is usually defined as someone with schizophrenia and severe bipolar. So, you know, people who are depressed, people who are anxious, often are not considered severely mentally ill, even in these statistics, even though I'm certainly aware that people with depression and severe anxiety can be severely mentally ill. What we know is that people in this with severe mental illness in the California's mental health system, we found that 15% were homeless at least one time per year. And I would say in Nevada County, our numbers are higher than 15% of our folks, of our severely mentally ill folks. Oh my goodness. Okay. Oops. So just to compare that, I mean, mental illness is a lot more common than any of us want to admit. But 1 in 5 Americans will have a diagnosable mental health condition in any given year. So a mental health diagnosis can be, you know, you're having anxiety, you're having a hard time adjusting to a loss in the family. So these numbers are not really comparing apples to apples. But it's still, mental illness is pretty frequent. 50% of Americans will have a diagnosable mental health condition in a year. And most of these conditions start by the age of 14. Substance abuse disorders in people who are homeless. We find is that, and again, these are conservative numbers. SAMHSA says that 38% of the homeless population are dependent on alcohol, 26% abused other drugs. 2/3 of the homeless people reported that drugs or alcohol were the major reason for them becoming homeless. And what we also know about, if for folks who are homeless, if they didn't have a drug and alcohol problem before, they frequently get one or become addicts because of just it's a way of coping. Not only in the homeless population, we also find chronic illness. Among people who are homeless, 31 to 46% report having a chronic medical problem. So Nevada County, how does this work for us? Let's see if I can get this in closer to you guys. Whoops. Oh, goodness gracious, sorry. So these are our Nevada County numbers. So how many sheltered people did we have in 2015? Here's our numbers. And as you see, in 2015, we had 25 sheltered homeless children. To me, that's pretty impactful. And how many unsheltered did we have? Here are our numbers. And again, we had 17 unsheltered children in Nevada County in 2015. That we counted. And one of the things I've spent a lot of my life in working in child welfare is what we know about children on the streets is within 24 hours they're exchanging sex for basic necessities. So one of the concepts is that, you know, if you have good services, more homeless people are going to come to your community. So in the homeless count, HUD asks us, by the way, there's a series of questions we have to ask everybody, and I've been out on these homeless counts. It's pretty impactful. I'll never forget them. But so we asked people, how long have you been in Nevada County? And 22% said their whole life. Another 37% said for greater than 5 years. So, and another 15% said for about a year. Another 15% said between 1 and 5 years. So most of our folks that are homeless in our community are our brothers and sisters. They're our neighbors. Let me make sure I didn't skip something there. Oh yeah, and this is an important thing too. So we say to people when we're out doing the homeless count, why are you staying in Nevada County? You know, are you staying here because we have such great services? And I'll tell you some counties that have better services if that's what you're staying for. And no, the answer is, I mean, look, you can see most people have family and friends here. They grew up in this area. Some of them stayed for opportunities. And only you see the blue, the second thing. Those are the people that are staying because they have better social services available here. So you know the fear that if we build we build good housing. The fear that we give good services is that all of the people from Placer County and Yolo County and San Diego County, they're going to come here. We really find that that's really not true. So what is behavioral health doing to help our homeless population? First of all, let me just talk about who behavioral health serves, because I think sometimes there's a feeling that we're responsible to serve everybody in the community, and we're not. We serve people who have Medi-Cal or have no health insurance. So if someone comes to me and has private insurance, my team will help them get a provider, but we will not be the provider. And we serve the seriously mental ill. We serve adults with a severely disabling mental illness, and we serve severely emotionally disturbed children. In our community, we have 2 managed care plans that serve the mild to the moderate in the mental health world. That's Anthem and California Health and Wellness. How many people do we serve? We serve about 2,200. We serve about almost 1,300 adults and 824 children. And these are our conservative numbers, by the way. So what we do in behavioral health is we provide housing for about 144 severely mentally ill clients. And we know that most of these folks, if it wasn't for what we were doing, would be on the street. And we have a number of different funding sources, and I can talk about how we do that. So here's some of our strategies on how we do that. We, as you guys may know or remember, that in 2004, the state of California passed the Mental Health Services Act, and that is money that we taxed our people who made over $1 million. We taxed them an extra 1%, and that money went to mental health, and that money comes in different pots with lots of different rules and regulations. But we've been able to buy 2 homes. We have purchased with this money. These are homes in the community where we house a number of people, and one of those homes has staff in it 24/7. And then we have a grant writer, and I wish she was here because she should stand up and we'd all clap for her because she's so important to us. She has brought in 3 HUD grants where we fund 26 different units. We also work really hard at building relationships with landlords. I have people that are licensed social workers and therapists, and they're spending a lot of time schmoozing with landlords. They're spending a lot of time keeping people safe in homes, because what we believe in and what we know is true, the research shows it really clearly, is the answer is housing first. We don't say to someone, you need to get clean and sober, you need to get your mental health symptoms under control before we'll find you housing. What we do is we get people in housing as quickly as we can, and then we offer the services. And what we also know with the population we serve is that we need to give them very intense services to keep them housed. Because a lot of our seriously mentally ill folks and people with serious addiction, get themselves kicked out of housing because of they scare the neighbors, they're punching holes in the walls, So we have a team, I have a team, and Kim is often part of that team, so we're glad you're here, Kim. We have a team that goes out to these folks and visits them, sometimes twice a day. We have some clients that need help with their medication twice a day. If they stay on their medication, they do fine, we can keep them stable. And so the team is made up of therapists, case managers, psychiatrists, nurses, and anybody else we can drag into the picture. And we create a plan, and our biggest plan is to keep them stable in their house. We have a person whose job is to get people on SSI, and that's a no small task. And we support master leases. So what we do is we'll say to a landlord, and we just did this with this great house in the Grass Valley area. We had a landlord who was willing to essentially give us this house, and it had 10 units in it. And what we do is, I know it's a big find, and we're really excited about it. What we do is we guarantee the landlord rent, and we guarantee that we will keep the maintenance up. And so the landlord is just given this check every month from behavioral health, and but we are able to place people in this home who we, again, case manage and visit, for some of them, for the rest of their lives. And if an apartment is empty, and by the way, our apartments never stay empty very long because we always have somebody that we know that needs to be housed. And if we pay the landlord that whether or not his units or her units are full. So how do we maintain housing? This is what I've talked about already. We see clients frequently. We help with medication compliance. We help connecting them to other health care. We help connect them to drug rehab. We drive them. We do whatever it takes to keep them housed. So, you know, we do things like, and for the houses that we don't have master leases on, we help with security deposits, we obtain furniture, household goods, and we make repairs. You know, this team, my team meets every morning. I don't know why. They're right outside my office, standing in the hallways, and, you know, they're saying to you, you know, you need to get over there and help him clean that carpet. And, well, did you know that the toilet backflowed? And I'm worried that so-and-so has relapsed. And the landlord just called us because so-and-so's sleeping on got friends that are sleeping underneath the porch. So we do whatever it takes to try to keep these people stable. So one of the things that happens often is that folks are released into homelessness. They're released out of the jails, they're released out of out of our psych hospitals, and they're released into homelessness. If those clients are ours, by the way, because we cannot handle every one of those folks that are released out of the jail at 4 in the morning into homelessness. But if those clients are ours, we immediately pull a team together, and we will place the client in wherever we can find a bed. We have a crisis stabilization unit. We've actually placed people there. We have a respite center, which is a 4-bedroom home where we can place people. We have Odyssey House, which is a home where there's 24/7 staff, and we place people. This is all temporary housing, by the way. We know temporary housing is not the ultimate answer, but it's a short-term answer. And we place people in Odyssey House. It's our 14-bed unit, 14-bed home we have, or we'll pay for hotel vouchers and then our goal is obviously to get the person into into permanent housing. And you know, it was interesting. Just the other day, I was driving along and saw somebody beside the road who was clearly homeless, had a Safeway cart, and was scaring people. His behavior was really bad. He was scaring people, and I looked at him carefully. And he was one of our clients. We've housed him 3 separate times. We haven't been able to keep him housed. He keeps scaring the neighbors, you know, not being nice to the kids in the neighborhood. By the way, mentally ill folks are mostly gentle folks. And I think this guy's gentle too. He's just he's got a big bark and he scares people. So I was like, oh my gosh, this guy's homeless again. So I called the treatment team and said, you know, so-and-so's on this corner, you need to go see what we can do to help him. So I want you to know that some of the chronically homeless people in our community, behavioral health is aware of and is working with. But behavioral health we prioritize treating our homeless population. I have really a strong team, a dedicated team to this purpose, and we are aware that there's still a great need, and there's a lot more that we need to do in our community. So thank you.
Should we all sit up here, or?
Okay.
Oh, okay.
Oh, and by the way, here's the overview. It's on the piano. The overview of our 2015 homeless count. If you want more numbers. And I also have, I don't know, Senator Steinberg is making a potential, what are we calling it? A potential where he's hoping to take money for the Mental Health Services Act money and to build housing with it. It's called No Place Like Home. If anybody wants that, that's over there on the piano too that describes. Yeah, I know, now he's taking our money to build housing. Yeah.
Who's up next, Becky? Am I up? Okay.
Is this on? Yep. Well, thank you all for
coming out here. I've been learning a lot, actually. That was a really nice presentation. My name is Brian Evans. I'm the Chief Medical Officer at Sierra Nevada Memorial Hospital. I've been up in this area for 16 years, living in Nevada City, kind of in the downtown Nevada City area. And my background is in emergency medicine. I worked as an emergency physician in the ER at Sierra Nevada for 15 years prior to turning to the dark side of administration of the hospital. I'm really grateful that you guys are here with interest in this particular problem. It's a vexing problem, and when I look around the room, I see a lot of partners. And one thing I've learned in the last several years is that if we're going to solve these thorny problems, it's going to require a real effort of partnership, similar to the one that we've had recently with building the crisis stabilization unit with the county and many other partners as well, trying to figure out how to sort of wrap our arms around mental health in this community, because it really does take a lot of different participants. My background in emergency medicine, I think, has given me a perspective that is sort of one slice of the problem. And Judge Anderson talked about the different ways that homeless people sort of end up in different situations and how we can effectively treat them, manage their problems, and some of those are very upstream and some of those are very downstream, and some of them are very expensive. I view the emergency department when homeless people are really overutilizing the emergency department, it's really a downstream kind of a place for them to get their care and get what they need, and it's extraordinarily expensive. And I hope to make the point that it's a big problem for all of us. It's not just for them. It's not just for the hospital. But it's a problem for all of us in a variety of different ways. Similar to the way that it's extremely downstream and expensive when they end up in the criminal justice system, and that is absolutely not where we want folks to be. There was a study about 10 years ago at UCSF. They have a large homeless population, obviously, in San Francisco, looking at the utilization of the emergency room depending upon whether someone is homeless or housed in some fashion. And they defined a category of marginally housed versus unhoused people in the San Francisco area. Those that are marginally housed, and marginally housed means that they just have some place to go, basically, use the emergency room way, way less. There's an enormous decrease in the utilization of the emergency room for people that have a place to stay. If they don't have a place to stay, they use the emergency department because they don't have any other choice, quite frankly, and there's no blame about it. It's just they need certain things to help them deal with whatever medical problems they have. They need a place to go, and they come to the emergency department, and it really is kind of the safety net for that community. So in Grass Valley, it's here in Nevada, we've certainly seen a very large number of people coming into the emergency department, and I can tell you it's a frustrating thing because I feel like when they come to our emergency department with a variety of problems, we have certain tools in our tool bag, but we don't really have that great of a tool bag for that problem. People come in and they've got housing issues, they've got mental health issues, they've got substance issues, and they've got medical problems a lot of the time that are really undermanaged. And we don't really have all the answers. We don't have great solutions in the emergency room. Some folks end up being admitted when they didn't need to be. Some folks we really can't discharge because there's no place for them to go. And that problem has been on the increase. I view the homeless issue as not just a discrete issue, but it really is a huge amount of overlap with mental health and certainly with substance disorders as well. So, I am optimistic that we have a lot of resources and a lot of people that are interested in addressing this problem in a more significant way. I do feel like we have some great partners. I'm gratified by what Becky said and, really being part of the solution. I'm very gratified that we have a Superior Court judge with so much compassion. So thank you very much, Judge. And I definitely think that the hospital is one of the partners that needs to be participating in the solutions going forward. But what it can't be is sort of the last resort scenario for people with homelessness and for the hospital just to try to solve problems without the resources that are out in the community. And I can tell you that the success of the hospital, the stability of the hospital, the finances of the hospital are important to every single person in this room, in the entire community, because things have gotten very challenging financially in healthcare recently for hospitals, and we won't be able to shoulder the burden by ourselves. And I know that we aren't, and I'm appreciative for all the help that we're seeing in this room. Thank you.
All right, so hi, I'm Stephanie Kreider, and I am the Community Health Benefit and Outreach Specialist for Sierra Nevada Memorial Hospital. It is a new position for the hospital. I became the Community Benefit Liaison. It would be about May of last year. And community benefit is not something unusual. We're a nonprofit hospital, and as such, we are required to maintain a certain level of community benefit. But what was clear in May of last year was that our traditional means of providing community benefit were not significant to make a difference in the health and lives of the individuals in the communities that we serve. So Dignity Health and Sierra Nevada really began to look at a strategic approach to improving community health. And one of the ways they did that was to utilize the community benefit individuals who already had, in many cases, relationships with community partners and other nonprofits. And so they decided that they would use the community benefit to bridge that gap and really start making a difference. So I was hired full-time to do this job. And my job and my work aligns with community health needs assessment that is done every 3 years. And that looks at the health of the community overall, statistics, things like what diseases are present and what real factors are creating issues with real sustained health in the community. Right now, those clearly are mental health, substance use, access to care, and chronic disease. And so that is what I work towards. I work towards trying to make marked and sustained improvements in those areas. And there's no way that I can do that by myself. So I really rely on creating collaboration with our partners in this community. And I can tell you, being associated with Dignity Health in the Sacramento region, this community is leaps and bounds ahead of any other area. We are on the forefront. We have got everybody at the table looking at the picture together, willing to make real change, but what we need is funding. And so when we have that, we make a difference. SB 82 funds came through and we were able to create both the crisis stabilization unit, and the county was able to develop their respite center. Two fantastic things that have been done in this community for the population that deals with mental health issues. And those would not have been possible if we did not get those funds. And then, what else? What else we're doing? We've got collaborations now in this community around mental health. We continue to meet quarterly, and we continue to look at what is next. And we are working together with what limited means we have to make a difference, waiting till the next thing comes forward so that we can seize it. We're all poised. We've got substance use collaboratives in place, getting ready to do significant work in that area, and that is extremely exciting. We are working together now to improve access to care and chronic disease. But you know what is common in each one of those areas is the issue of homelessness. It is so difficult to really really sustain that care and make improvements in these individuals' lives if they don't have that basic need. The key social determinant of health is basic needs: homes, housing, and food. If we don't have that, how do you discharge somebody from the hospital with diabetes who needs to refrigerate their insulin without a refrigerator? Like, how do you do that? How do you keep that person healthy? How do you give them their insulin syringes when they're going to be beat up and have them taken because the person needs them to shoot up heroin? I mean, it's just a very difficult situation, and without that housing in place, it's very difficult to do what we need to do for this population. So we're working together. We've got great things going on in this community, but we do need help, and we need that through funding. So thank you.
Hi, everyone. Can you hear me? I'm Katie Bell, and I am a addictions nurse. I'm board certified in addictions, and I work at Shop a Day Indian Health, and I'm here at this table with some of my favorite collaborators. We work together on the challenges of treating the substance use disorders in our community, and as Stephanie said, a lot of change is coming. But I want to just tell you a story that, because I'm on the front lines, I am meeting the patients all day long, doing interventions, picking up the phone and talking to mothers that are desperate. And this includes our homeless day in and day out. So when I speak about our addiction challenges, understand that we're speaking of people who do not have homes. And so I got a call about 6 weeks ago from a mother who was desperate. Her son had been living on the street, and he had been using heroin for a number of years, and he had lost 12 friends in 3 years to overdoses, and he was ready to come into treatment one more time. And the desperation in this woman's voice is still with me. And I've gotten to know her a little bit since. But anyway, she got her son into detox through the fantastic county that we live in. And he got into CORE. And after 30 days, he and 2 other young men completed treatment, decided they were going to get an apartment together, go to school. We got our lives back. Where there was so much youthful relief and joy, and we're going to get jobs. And they got moved into their new place just a few days after discharge. All 3 heroin addicts, and one of them obtained some heroin, and 2 of them died. This was in our town. 2 of them died, and I think it's important to understand that when one of the most dangerous things for a person who's using heroin for them to do is to get sober, because the tolerance for the drug in their body and their brain has been reset. And I think the judge knows this too, that when somebody has been in jail and they've gotten sober, clean, they go out and they encounter a friend, they're higher risk. We need to know that. We need to know that as a community, that this is just sending somebody into treatment is not going to be good enough. Because if someone leaves treatment without a good follow-up or medication-assisted treatment, which is opiate replacement therapy, which is what we're working on big time here, we need to know that. And we need to communicate that to each other. Everyone in this room knows somebody with a substance problem. Often it's alcohol. So I just wanted to share with you that this is a real thing. There are real losses. And we're all really angry and frustrated. Any one of us that has a substance user in our lives often feels just so angry, so frustrated, so unable to make changes. And because this is one of the most complex diseases, this is a chronic. Wow. Woo. All right. All right.
I'll turn it off.
Thank you. I was just about to tell you all my secrets. And, yes, just turn it off. So anyway, the whole issue is that this is a chronic, progressive, relapsing disease. This is a disease. It is not a moral problem, even though people really drift away from their moral center. We see that. And it is often because, like, for example, I'm going to use heroin and alcohol, but any drug. The brain is changed by drug use. And there's this thing called craving. I don't know if anyone here has ever craved chocolate or craved sugar or craved anything. It is a very powerful, persistent thought. Or tobacco, we all know about craving, we're humans. So the part of the brain that craves is more powerful most of the time than the part of the brain that says, no, I can't do it, or it'll make me fat, or that's what my executive function says. So we're dealing with something that needs to be addressed in the brain. So if someone needs to have heroin or needs an opiate or needs a drink, often they will compromise their moral center. The hierarchy of needs change. No longer do you need safety, you need your drug of choice, correct? This is what happens. This is the hierarchy of needs is hijacked by a brain that craves. And that's what we're doing in addiction medicine, is really bringing that understanding and treating it. And there's lots and lots of breakthroughs in studies. And so the town, the perception, the common village presence really needs to see it in new ways. And I invite everybody here to see addiction in new ways, and I know that probably everybody in this room is doing so. That we look at it as a disease that needs to be treated. We don't punish people. The studies now are coming out that opiate addiction is very tied to childhood trauma. The VA, I was at the VA HICAM. We had, a lot of the vets came back from battle, and the way that they treated their post-traumatic stress symptoms was with heroin. It turned it off. So the self-medicating piece that we encounter in our homeless population is especially true, and also homelessness has been occurs because of the addictions and the alcoholism. So the approach has to change. The language is changing. We say substance use disorders. We don't use the word substance abuse anymore unless we slip, because we're all learning how to say it in a new way. Persons with addictions rather than addicts. We say relief seeking rather than drug seeking. The stigmatized thinking is shifting. And we're doing it together, and the humanity that we need people that are walking the streets without homes. We need them as positive citizens. That's so true. We need them. We need them back. It's not like we want to fix them. We need who they are. Alcoholics and addicts tend to be very sensitive, very creative. They're full of gifts. And for us to begin to see that by transforming the most vulnerable, we are going to receive unique gifts, art, new thinking. People often identified as mentally ill are extraordinary creative thinkers, but we all know that. So what I want to point out is that drugs, street drugs, prescription drugs, are medication to some people. My first question when I'm doing an intervention with a patient is to ask them, what do you like about it? What do you like about drinking? What do you like about using heroin? And it's such a disarming question, because it's not, well, you need to stop. It's, what does it do for you? We all have these parts of ourselves that we get relief. Life is hard. And if you're homeless on the streets and you're struggling with a mental illness and you can't keep track of your meds, you're going to use something else to relax, to relieve the pain of life. So if we started seeing other human beings who use drugs and alcohol as people who are suffering from a chronic disease, not as bad people, and I understand it's a lot of frustration there, and started looking for the ways that we are addressing it, new ways. The biggest problems that I'm encountering here is that we don't have a detox facility. So if somebody comes and says, I want to get sober, and I go, great, but don't stop drinking because you could die. You know, it's very unsafe to stop drinking, especially people who are drinking, you know, 2 or 3 bottles of wine a day. They're going to have to be treated medically. And so they usually end up over at Sierra Nevada, and that's, you know, that burden. It's tremendous. And they may come back, right? May be treated, come back. So what, if you want to know what this town needs for our citizens who suffer with addictions, and especially the ones who are homeless, who have probably the most chronic, difficult version of it, is we need a detox, and we need access to long-term residential treatment. It takes a long time. Those 3 young men who came out of residential treatment, they had a fantastic stay. They learned so much about their disease. CORE just provides amazing treatment in our town. We are so blessed. But getting them into the facilities is really a challenge. So we need to think, how are we going to do that? How are we going to pay for that? It takes everybody caring about this issue, because we need the people that are suffering. We need them. They belong to us, and we need them healthy. And if it's a family member, we really need them to be back, because everybody just worries. So so medication, anxiety, depression, auditory hallucinations, all of that is post-traumatic stress, all of that is managed by drugs of choice. So often when you ask somebody what their drug of choice is, you get a sense of actually what the underlying mental health problem is. So it's a self-medicating, chronic, progressive, relapsing disease that we can actually work with. So I just wanted to tell you a story. My granddaughter Mia is very interested in the homeless population in Nevada City. And we've done a couple of little projects for Hospitality House, and Cindy gave her and her little sister a tour, and she became very attentive. She began to see the people on the streets with backpacks and dogs. She began to love the dogs. She thought about the noble nature of dogs that stay with their people who are homeless. And her heart was really open, and we went out one day and just bought a whole bunch of rain ponchos. She became engaged, and she's going, well, I know about 5 families that could go out and buy all these. And she began to develop these projects. And then a few weeks later, we were driving out of one of the stores, and there was a woman on the side of the road, and she had a sign, homeless. And so we pulled over, and we gave her some money, and we rolled down the window, and we talked for a while just to kind of get to know her. And I asked her name, and I introduced ourselves, and we talked a little more. And then when we were going on, I asked Mia, I said, why do you think we wanted to know her name? And why was it important for us to introduce ourselves? She said, I don't know. I said, well, the most important thing for every human being is our name. And now we know her name, and if we see her again, we're going to pull over and say hi to her. And that's the first part of our humanity, is our name in a lot of ways. And she just sat there and she thought about it. She said, how do you know all this stuff, Grandma? But it's the little stuff. It's the invisibility of our homeless population. We can all direct our gaze, simple things, direct our caring, direct our interest. It doesn't have to be a big project. It can be noticing the noble dog. That's how we change. It's you know, my favorite quote of Mother Teresa's is we cannot do great things, but we can do small things with great love. And that's how we are changing, all of us are changing our community, whether it's substance abuse, see, I said it, substance use disorders, addictions, the amazing people in the ER that greet our most vulnerable day after day, day in and day out, that kindness. I have a patient that is his safe place because of the kindness. That's what he needs. That's why he goes there. So we're in this together. We're all going to do little things every day, and that's how it's all going to change, is paying attention, listening, learning, thinking in new ways about addiction, and accessing, all the resources. There's many resources, and the more we know, the more we can do. All right. Thanks, everybody.
So I want to thank our panelists for their presentations, and now we are going to ask them to answer the questions that you have submitted. You can still submit more questions if you'd like during this period by raising your hand. So we will have people come to you with cards or to pick up the cards with questions you want. Tom is in charge of the questions now, and various people on the panel will be answering them if your question was directed to a specific panelist, and we'll have an interesting conversation here.
So the first question, we go to Kate. Where do alcoholics and drug addicts get their money for their drugs and alcohol?
Wow, that's a great question. So Becky probably knows the answer to this more. Where do they get their drugs money?
Anywhere they can.
Anywhere they can. So what?
And
Yeah.
sometimes
Yeah.
exchange sex for money.
The question was, where do alcoholics and drug addicts get their money for drugs and Did you hear it that time?
Yeah.
Okay. So, and I'll add a little something to that is, what I know from talking to clients, when I was an attorney, talking to people that I'm sentencing and their caseworkers, you have people who are crashing at places for a place to live. They may have a Social Security check. They'll lose that check to the people that's letting them crash there so they can get money for drugs.
Yeah.
There's a lot of theft that goes on in the county where people are actually stealing pretty minor things, minor amounts, actually, most of the thefts. But they're using those to sell the used tools, they go to a pawn shop in another town and get a little bit of cash. And if it's enough to get high, then they're successful.
Good answer. The other thing is that often there'll be prescribed pills that they'll trade for. The whole prescription pill has been a big topic because of the addiction, but often people will sell their sleep medications for a can of beer.
And of course, the accessibility of heroin in our community has increased dramatically over the last year or so. To be quite frank, the cost of heroin is cheaper than marijuana now.
Yeah.
So,
It's the gateway drug.
Gateway drug.
So heroin is now the gateway drug for youth, and it's no longer marijuana because it's so cheap.
so another question, and we'll start Dr. Evans, and then Kate probably. Nevada County seems to experience high opiate use. Does the medical community second guess its use of prescription opiates?
Yeah, I would say that there's been a huge amount of overprescribing of opiate medication, not just in this community, but throughout the United States, and it's something that has really been a problem, and I think it's been a contributor to opiate addiction throughout the United States. There's definitely new focus on that. There's more awareness of that among providers to really not just limit the number of prescriptions that are being given out for pain medications, but also be a little bit more of a team and make sure that we're not having multiple prescribers giving prescriptions to patients. And there's now actually there's a database called Cures, which providers can look at and figure out who is really the primary responsible provider for a patient who gets pain medication. And physicians will actually be required now to register and use Cures so that there is a much better collaboration among providers, and we're not, inappropriately prescribing for multiple sources. But I can tell you that the biggest challenge, and the reason for it, is that when patients come in with pain, there is a very large concern about under-medicating patients that have severe pain, and it can be extremely difficult to sort out whether the patient that is in front of you that is writhing in pain and in obvious anguish is experiencing, if that is due more to an addiction issue or more to an actual painful condition. And as a prescriber in that situation, many times over the years, it's very tough to say, no, I'm not going to treat that. I'm not going to give you something that is going to help you. I'm going to, because I'm concerned about an addiction or something like that. So it can be a little bit of a challenge, I would say, being in that position. So I do feel optimistic that now with the awareness that's out there, with more of a teamwork approach to it, and with the Cures database, we have new tools that are going to help us along those lines. But overprescribing is not going to go away anytime soon. It's going to be an ongoing issue. So the answer, I would say, is yes. Yeah.
Please.
So the CDC came out in October and said that the heroin and prescribed opiate pain pills problem is the worst man-made epidemic in modern medical history, and that 3 out of 4 heroin users started with pain pills. And so the medicine has shifted dramatically. We're like, okay, stop. That's how I came to Chop a Day, was to create a program for smart prescribing for pain medications. It was very difficult because whether you're misusing your pills or not, there is dependence that occurs. So after a while, it's pain and a dependence, and that's. And now that we're really being hyper careful, as we should be, the heroin is flooding into our community to meet that need, to meet that dependence. So it's not. It's just made a move. And I have a handout here. There's an article I listed called Kingpins, which is about both the pill cartel and the heroin cartel. It's a very interesting story, so I encourage you to look for it.
All right, maybe a different tangent that we can go on for Dr. Evans. Why is the waiting room so noisy with blasting TV? And the 3-hour wait.
3-hour wait. Well, the blasting TV, I didn't even know there was a TV in there. Is there a TV in there? Yeah. Okay. All right. Well, I can take back. Maybe Vivian and I will take that back to the hospital and ask why the TV is blasting in there. I don't know. The 3-hour wait is tough. Overcrowding in the emergency department in our hospital and every hospital virtually in the entire United States, it's really a common problem. And the problem is that the emergency department is the safety net for our entire community. And when we don't manage problems such as homelessness and substance disorders upstream, we end up getting them downstream. And so our emergency department here in Grass Valley is no different. We end up with overcrowding because of the demand. And it is a very difficult problem to solve. We actually would love to be able to just double or even triple the size of the emergency department and add tons more staff and just build our way out of that. But that's not a very realistic solution financially for us. And if you look down at other communities, they're experiencing actually worse overcrowding than we are. We're part of the Dignity Health system. There's 6 hospitals in our region. And we are on the low end of the waiting times. If you go down to Mercy San Juan, you're potentially going to wait all night long to get seen in that waiting room. I trained at UC Davis. People literally would register in the evening and they wouldn't get seen until 6, 7 a.m. So it's a societal problem more than it's a Grass Valley problem, but we certainly do try to see everybody as quickly as we possibly can.
I can tell you that there's a lot of work going on, both internally and externally, to really deal with the ED crowding. Internally, they're working on teams that move patients much more quickly from the emergency room setting up to the floor when necessary. But then we've also got teams working on things like primary care utilization in the emergency department. That went up 1 year with the managed care plans from 1,800 to 4,800 individuals, unduplicated individuals, utilizing the emergency department for primary care related diagnoses. So those individuals should be seeking care with their primary care doctors. So we have navigators now in the emergency department who are working to identify patients without doctors and getting them connected to a doctor, but build that relationship and help decompress the emergency department. The huge thing that's helped for us is the crisis stabilization unit. And that, I've been doing some data analysis on that. We were looking at an average of approximately 29 hours per patient who needed higher levels of psychiatric related care. They were being boarded in the emergency department for up to, on average, 29 hours. And with the crisis stabilization unit in place now, we are seeing times it comes out, because the way we look at it, it's approximately 15 hours now. We've reduced just since the crisis stabilization unit has come on. So it's huge. We are making improvements. It's slow, but we're trying. We're working towards making that better.
It's a team.
It's a team.
There is a question about the concern of the fate of Progress House. Do you want to address that?
Sure. So first of all, just a little history. Nevada County owns a old farmhouse that has been zoned years ago, which is the real blessing, for drug and alcohol treatment. It's an old building that needs a tremendous amount of work. So we got a federal grant of $500,000. We're going to be totally redoing that building. Progress House has had that building rent-free for the last 5 years. And we're asking Progress House to leave while we redo the building. We're ripping it down to its studs and anyway, it's going to be pretty slick, and we're going to have a 19-bed unit. And then after that, we are going to put it out for what we call RFP process. It's a process where we say what we need, and Progress House and other drug treatment providers will apply to be the provider in that situation. And then we'll have a committee that will choose the best provider. We will be inviting the hospital to be part of that committee. And this is your first invite, so I hope you guys come. One other meeting for you to attend. I know you can't wait. And we'll have a community members also on that choosing team. So Progress House, if they choose to apply, can apply, and we'll hope to release the RFP soon, and hope really by October to be open. So it's really, actually, I personally, I think it's a really exciting thing that this old building's going to look really nice and be nice, and we'll have hopefully 19 to 20 beds for long-term residential drug treatment.
There's several questions asked today, and they've been asked even before the event happened. I had noticed that these questions would be asked, and I tried to find an answer. And the question relates to the fact that the jail releases people in the middle of the night, often without proper clothing, money, transportation, and folks without shoelaces, sometimes without their gear because it was left at wherever they stashed it before they got arrested. And to be quite honest, I can't give you a direct answer of why they have that policy. Several times before a public event where this question should be raised or addressed, I've sent questions over to the current jail commander, hoping to get a response. I get responses about some of the process and procedures that the jail has always used and have been in place. The jail commanders, for the most part, are obligated to follow the procedures that have been given to them, but there's no explanation as to why it's done in this manner. And it's a troublesome situation. Just not that within the last couple weeks, somebody with significant issues known to law enforcement was released sometime between midnight and 4 a.m. wearing summer clothes, released in the cold and wet. Fortunately for that person, Officer Shane from the Nevada City Police Department was on duty, was notified this person had been released for some form of communication, went and picked him up and made sure the person was safe and didn't die in the cold. But that goes back to one of the core things that everybody's discussed, we're talking over. There's a couple, in my mind, 3 basic words that wrap up what we all need to do and what needs to be done. It's housing, communication, and kindness. Okay. And we need everybody, all the different agencies, to communicate with each other and create some procedure where the communication can occur when it's necessary, when it's most needed, not at the next meeting. So through the hospital, they've been creating some collaborative associations trying to bring in a lot of the players together to start bridging this communication gap. And that's something that's been ongoing for quite a while. The Forensic Task Force has been at it for 16 years, 17 years. It's not an easy process because personalities change, leaders change, which is why we need to find a way to make this a part of a system, an ongoing system. Anyway, so I'm sorry I couldn't answer that question. Dr. Bryan, have the psych beds discussed been established?
The psych beds in the crisis stabilization unit, I'm
Yes.
thinking, is what that refers to. Yeah, the crisis stabilization unit, CSU, opened on December 14th, I think. Is that right, Becky?
Can you describe how that works?
How the process works?
Yeah.
Sure. So the historic problem that we've had in the emergency department and that most emergency departments have is that people come in and in some sort of a behavioral health crisis. They have an evaluation done by one of our crisis workers. The county contracts with a crisis worker group. The patient is placed on a hold, a psychiatric hold called a 5150. And then they're in the emergency department and they need to go to a psychiatric facility. That is basically what needs to happen next, if they're medically clear, if there's no medical problem. So before the CSU started, the crisis workers would start calling all over the place to various psychiatric hospitals to see if we could transfer our patient down there on their 5150 hold. That's where they have to go. And as everyone hopefully knows in this room, there aren't a lot of beds out there. And typically it was a lot of phone calls and a lot of, no, we don't have any beds right now, we'll call you later when one opens up. And that process can take a long time, an average of, what'd you say, 29 hours?
Well, no, that's more than that, but yeah.
Yeah, so, and I can tell you, I've had patients in the emergency department for over a week, sitting in the emergency department, literally in like exam room 2, waiting, and it is like a little prison for them. It is really a terrible place to be located, especially when you already showed up with some kind of a mental health issue. So it really is not appropriate. It's not kind, and it's not good, and it's terrible from a financial point of view too, I can tell you. So the CSU opened up now. Under many situations, but not all, the patient can then be taken over to the crisis stabilization unit, which is a much more appropriate facility for them to be in. It is conducive to healing. The patients do quite a bit better. It's much more relaxing for them, and it decompresses the emergency department, so then we can take people that are there for other medical problems, put them in that room, in that bed, treat them, and turn the room over, many times. and clear out the waiting room. So it's been extremely effective. The beds are open. There's 4 of them. It'd be great to have a bigger crisis stabilization unit, but that's what the budget allowed, and it's been fantastic. And very few hospitals have this kind of an arrangement. I don't know of a single other hospital that has a partnership with the county where a crisis unit was built right outside the emergency department in that manner. So the fact that we were able to pull it off was really fantastic for really all of us, including those of us who are just trying to get into the ER to get our broken arm dealt with. So it's been a good success, I would say. Did that answer the question?
I think so. Follow up? Okay. This is a question probably goes to everybody, so we'll just they're sent to Dr. Evans and Becky. Being clear that one of the fundamental underlying problems for all is the lack of mental health facilities, what should the county do to help with this on a local, regional basis? And a complementary question was, has consideration been given for a county-locked psych facility for assessment and treatment, or at least a jail psych unit? And I can eliminate the jail psych unit question quickly. No. Cost and population is a big part of that, but the others.
Yeah, I mean, I think we talked about that just a little bit about the CSU. As far as an inpatient psychiatric facility that would be beyond a crisis stabilization unit, that has been talked about, but I think the cost of it is prohibitive at this time. There is an inpatient psychiatric facility in one of our sister hospitals at Woodland, and we work pretty closely with them. I believe they have 30 beds. Is that correct? I think it's 30. So we do use Woodland, unfortunately. It is full all the time. It is full all the time. I mean, there is a huge shortage nationally in inpatient psychiatric beds, and we're absolutely affected by that. Yeah, I know that there was talk about Rockland getting an inpatient psychiatric facility, and I'm not sure where that project stands, but there's quite a bit of opposition from the neighbors in that area to doing it. Yeah, Becky, I don't know if you have anything else to add.
We had somebody come to the community who wanted to open an inpatient psych unit, and we needed other counties to commit to buying beds, and we couldn't get enough counties to commit to buying beds. They've since gone down to the Sacramento area, changed one of our IMDs into a psych unit, but it's only for Sacramento clients. They won't take us, our clients. So there's an incredible shortage of beds nationwide.
Yeah, and one way that's manifest at the hospital is that a lot of times patients in the emergency room, they'll get admitted to the hospital and then they need to be transferred. We've had people in the hospital for a month, admitted to the hospital, and that's really kind of disastrous for the patient because that's not a good place for them to get treatment for their mental health disorders. It's also a disaster financially, and that impacts the hospital and all of you as well.
Question for Stephanie and Dr. Evans. You say the need for more funding for substance abuse treatment. Discuss how you've partnered with the community in other areas to free up funds.
We can talk about our system, the coming new drug management system.
Yeah, do you want to talk about that?
I can talk a little bit about it. I'm certainly not an expert, but I am joining the discussion now. We did put together a substance use disorder collaborative recently. We met for the first time in February. That group has really brought all the heads in to look at what we can do right now to make a difference. So we're looking at things like Dr. Evans said with the Cures database, making sure doctors are using that, kind of committing community-wide to this one provider, one source for opiate prescriptions. We're working on bringing more screening, brief intervention, and referral to treatment training to front-end responders. That way they are able to quickly kind of assess if this is a situation where a patient might be, or an individual might be willing to be connected to treatment. We're working on bringing education into the school system. We're working on increasing the availability of opiate reversal agents to front-end responders. That's what we're doing currently to try to bridge the gap. But there is a significant improvement on the horizon, and that is with the Drug Medi-Cal organized delivery system that's coming through, where right now Medi-Cal is does not pay, right? Is that correct? Does not pay for any detox substance, like residential substance treatment, and that is a significant gap. Our population here has a very large number of the managed Medi-Cal and the Medi-Cal population with no access to any paid opportunities to detox from their substance use disorders. So that's coming down the line. It'll provide funding for 90 days of residential treatment, but that's not enough. And it's part of that program is realizing that that is not enough, and we need to create a whole network of support around that, including medication assisted treatment, so that patients aren't, as Katie alluded to, just going without any support for their opiate addiction, putting them at risk for these really dangerous relapse scenarios down the line. There's the need to really have targeted outpatient treatment that incorporates mental health treatment, because it is a significant part of that disorder is the mental health component, as well as case management, because these people really need to be networked and to be connected with all the services in order to be successful. So that is significant. It is a huge improvement from what we have and what we've been dealing with. It's coming down the line. We have a little bit of time before that is implemented. So right now what we are doing is trying to leverage what we have, the strengths that we have in this community. Add anything?
No, I think that was all. You summarized it all pretty well. I would just say that my jobs have mostly been on the well downstream aspect of care, frustratingly downstream. And as voters and as an advocacy group, when you think about whether funding ought to be increased, whether you ought to vote for something or advocate for something being funded, I can tell you, if you're voting in favor of more dollars being spent on substance abuse treatment or prevention in the schools, that kind of thing, I would strongly recommend you advocate for that, because if you don't pay for it up front, you're going to pay for it 3 or 4 times more down the line when I see them in the emergency room, or we admit them to the hospital, or they're on the streets. So I think that that could be the role of this group, certainly advocating for that.
Tom had to step out. I've been given the job of reading the questions, and these two are my questions. So well, let's start with the first one. How does your team conduct the homeless count, and where do you go to find them? Okay, it's not just my team that does that. It's essentially people who get the HUD grants. My team, Hospitality House, Salvation Army. So we have a group of people that come together, and we have, especially a Hospitality House, and I have a couple people in behavioral health that really, really know, spend 40 hours a week plus out in the woods talking to folks that are homeless and outreaching to them. And they know where to go to count people. We have everybody in the county is responsible for counting, and we're always looking for more volunteers. So if you think you have some inside knowledge where homeless people are and could help with the homeless count, please join us. You're welcome. It's a very it's a life-changing event to be part of that homeless count. When I go out to the camps and talk to people, I'll never forget what those people have told me, and I'll never forget what I see out there. So that's a kind of interesting segue to my second question, is that assuming that more housing can be procured, I think are the ways that they're saying, is there sufficient behavioral health staff available to help them? And probably the answer is no. And the answer is no. And my personal goal, as is my boss's personal goal, Michael Hegarty, is to figure out the funding so that we can increase our team that outreaches to the homeless. I won't bore you with behavioral health funding, but essentially, for every dollar I spend, I get 50 cents federal money, and I have to find another 50 cents of local money. And so that is what slows me down, is that other 50 cents of local money. So, and there's of course lots of rules about where that 50 cents of local money can come from. So we have a team our fiscal leaders and myself and Michael and our CEO's office, we're really doing a lot of brainstorming around this issue of how we can increase our essentially our wraparound program. And we were hitting a lot of dead ends, but we're not done. We're not done. We're going to figure this out.
And to add to that just a bit, when we talk about statistics and expenses, like the reduction in cost to have a problem-solving court versus just traditional prosecution and punishment, or in the case of like Laura's Law, where the cost for the individual who comes into Laura's Law, which is assisted outpatient treatment, it's a behavioral health program that works with the courts to encourage people who are rapidly decompensating and likely to end up in a hospital to get them stabilized and maintain their stability. And it's a very proactive program, and it does save a lot of money. I mean, the county behavioral health department a few years ago got a National Association of Counties award because of the remarkable savings they can get from this program. But those savings are spread out for the most part across the community, not for one particular department or agency or one silo, if you will, compared to another. So one silo may not see a big difference, whereas the ER might see a little bit reduction, or the jail might see a reduction, local law enforcement would see a reduction, but it's not spread evenly or even in a manner that you can really calculate it effectively. But when those who have done the deep, long-term studies, have shown the huge savings in doing problem solving rather than just reacting. But it's hard to budget that way. So it makes it very difficult for departments who are limited county budgets to, take on everything that needs to be done and even do what needs to be done when they know what it is. And that's where we go back to leadership, priorities, focus, motivation. Let's see, there was a question about, going back to earlier question about when law enforcement has to take possessions of homeless folks, that is, somebody gets arrested and they have their belongings. Oftentimes, it's not really so much, it's not ill will of the law enforcement. They may take their belongings and they collect them and they put them, say, in the police station, and the person goes to jail. They get out of jail, but they're getting out at 4 a.m. They can't go to the city building until business hours. So if if they're getting released on a Saturday morning, they have to wait till Monday to get their stuff back. That's a real problem. It's not the police's fault, but it's depending on the nature of the arrest, how much stuff they have with them, where it's put. When they bust homeless camps, for example, they try not to take their stuff. They often give them notice that the camp's going to be closed, give them a chance to move. It's a complicated procedure. Sometimes it also depends. We know that the Nevada City and Grass Valley police departments are very sensitive to that and do their best to accommodate. So it's a difficult problem, and some of it's just practical. If we had 24/7 caseworkers who could go to the jail when somebody's getting released at an obnoxious hour without sufficient clothing and a place to go, that could intervene in that. And I think that's something, hopefully this group, we're all working towards, but it's just one of the many problems. I mean, you start looking at all of these issues, there's lots of tangents, and it's hard to keep them all together and figure out which ones work with each other. And I'm always reminded of the logo of Sierra Roots, which I think is an ideal logo for that. I don't have a copy of it, but I do have something similar, but it's not big enough to show everybody. But it's basically something like this: a full tree with a full set of roots. It's all connected, and you need all of it to approach the problem. Yes. You're standing up, so it must be important.
Well, I think we have a couple of important things to address before I thank the speakers on our panel for doing an outstanding job. I want to respond to a couple of questions that were submitted by the audience. One is, will you put the PowerPoint on the League website? And yes, our president has agreed that that's a great idea. The other is, how do the homeless vote? Well, that is certainly a good and pertinent question here. The homeless are entitled to vote, but they must be registered. The last day to register is May 23rd. You may be aware that the League has a Get Out the Vote program that is operating throughout Nevada County, collaborating with business, the Chamber of Commerce, and other organizations, because not only is it a worthy cause, but we hope that we will have the highest number of registered voters of any county in California. A worthy goal. We are registering voters, and the next opportunity for local voters to be registered through the League will be at Mateo's Public on March 23rd, 5 to 9. And Mateo's is donating 15% of sales to the League of Women Voters of Western Nevada County. So you can register to vote and get delicious food, beer, and wine while you're accomplishing your civic duty. So this is a good point at which to thank you all for coming out today. Joanne?
I just wanted to say homeless registration is they just need a cross street. They don't have an address, obviously. They just need a cross street.
So as Joanne is reminding us, homeless people without a home base, an address, can register by using cross streets near where they're located. Also, I understand that Hospitality House often functions to assist homeless people with the issues of getting registered to vote. So I also want to let you know that we are requesting that a homeless person who was involved in our meeting today write up a little bit explanation, description of their experience of being homeless, apparently for about 7 or 8 years. And we are hoping to publish that on our website to give us all some insight from a different perspective into this very difficult challenge. So without further ado, I want to thank you for coming. I want to thank our wonderful speakers today, and I hope they can stick around for a few minutes in case you have some questions. But before we conclude, I'm going to, Kim Grubbs has asked for a few minutes to let us know the outcome of another important project that many League members were involved in. Kim? All right.
Hi, I just have a few minutes, but I also wanted to just dovetail real quickly to help. If you ask when they come into the ER if they're a veteran, the transfer coordinator at Mather and also at Reno will help, and that will relieve some of your burden.
They do ask.
Okay, good. Okay, so the VA and the Care Force work together for the out of Sacramento, the California Care Force and the Women's League of Voters gave $500 towards this huge project. And I don't have a PowerPoint because I didn't have enough time, but I have pictures. And what it did was it provided for 2 days in November of 2015, but they do it every year, medical care and dental care, actual dental procedures. So I was going to pass these pictures around. There, those 2 pictures, if you can pass those around. These were actual procedures over at the Veterans Hall that happened, and three of our veterans were homeless, benefited. They had their entire teeth removed, and they now have a full set of dentures and teeth. But this care force that the League gave money towards also helped children who were homeless, who had not had dental care, had not had any shots. I volunteered tonight. They had me over at the school, so we were giving shots. We even helped a woman, a girl whose mother was an illegal alien and didn't have a social security number, had a blood sugar that day of 500, We gave her insulin. We got her connected with Western miners in Nevada City, I believe that's where they are, and she's now being taken care of. She was afraid because she didn't have a Social Security number. The reason I'm holding on to this one is because Dr. Lady, who is huge, in his picture is right up here, he had died 2 weeks before this happened. And he was a huge, huge contributor to this that happens every year. But the League gave money, and the food for the volunteers was amazing, and the effort was amazing. So if you guys want to pass that around. Thanks.
The first thing they told us in training is everyone will be called by their name. And every time we passed them from section to section to section, they were introduced. Hi, this is Sharon. She's going to have dental work. This is Sharon. She's going to have her eyes checked. Every single person was a person.
Thank you, Sharon, and thank you again for coming out to join us today. Our next program will be on transportation, an issue that also impacts